This is a question paper from MJPRU Bareilly. That is Mahatma Jyotiba Phule Rohilkhand University Bareilly of Uttar Pradesh. This university encompasses 4 medical colleges, 3 private and 1 government medical college. So the first one here is RMRI Bareilly. That is Rajshree Medical Research Institute Bareilly, Uttar Pradesh. The next is SRMS IMS Bareilly. That is Shri Murti Smarak Institute of Medical Sciences Bareilly, Uttar Pradesh. The third here is VAMC Shahjahanpur. That is Varun Arjun Medical College, Shahjahanpur, Uttar Pradesh. The fourth one here is GMC Budaun U. Government Medical College, Budaun U, Uttar Pradesh. Okay, now here you are seeing is a question paper of MBBS First Professional 2019 admitted batch supplementary examination of July 2021, although this exam was conducted on 3rd of August 2021. So this is question paper of human anatomy paper 1. I'm going to show you the entire question paper, so those who are preparing can revise. So this is part A, which is of 20 marks, had 20 MCQs, 1 mark each. And then you have is part B. Part B is of 40 marks, that includes subjective portion, and part C is also 40 marks that included subjective questions. So let's begin with part A, that is of MCQs. So we're going to solve these 20 MCQs one by one, and I'm going to explain you the answers. Question number 1 here is occipital belly of occipitofrontalis muscle is supplied by posterior auricular nerve, greater occipital nerve, lesser occipital nerve, third occipital nerve. So for this you need to know this. Right, so here this muscle is, the frontalis muscle. The important point about this muscle is that this muscle has no bony attachment. It attaches actually the upper margin of the upper tarsal plate of the upper eyelids. Then posteriorly you have these nuchal lines, the superior nuchal and the highest nuchal lines. So onto the highest nuchal line you find these fleshy bellies of this muscle called the occipital bellies. Both these fleshy bellies are connected by an interconnecting fibrous aponeurosis that's called galea aponeurotica, and that forms the third layer of the scalp, aponeurotic layer. And that's why this muscle is also in a category of digastric muscles, a tendon holding the two muscles on the two sides. Now talking about the nerve supply. So you know that here this nerve emerges out from the stylomastoid foramen, and then it passes through. Here you find is this parotid gland, right? So you find is a parotid gland placed here, and this nerve, when it emerges, it pierces and passes through this parotid gland to give out its 5 branches: temporal, zygomatic, buccal, marginal, mandibular, and cervical. And one branch passes behind posteriorly like this, behind the pinna, right? Here let me draw the pinna so that you remember what I'm telling is here it is the pinna, right? And onto the pinna also you find these muscles. These are the muscles. This one is anterior auricularis, superior auricularis, and the posterior auricularis. So talking about the nerve supply now, remember that frontal bellies of occipitofrontalis, this is innervated by the temporal branch of facial nerve. This branch also innervates these muscles, the anterior and superior auricular muscles of the pinna. However, this posterior auricular branch innervates the occipital bellies as well as the posterior auricularis muscle. So the occipital bellies here you can see they are innervated by posterior auricular branch of facial nerve. This also supplies the auricularis posterior muscle. So the answer here is occipital belly of occipitofrontalis muscle is supplied by posterior auricular nerve, which is a branch of facial nerve. Let's move to the next question now. Which of the following structures does not pierce buccinator muscle? Choices are parotid duct, buccal branch of mandibular nerve, buccal branch of facial nerve, molar mucus glands. Okay, now let me explain you this. So imagine what I'm drawing here is an oral cavity. Let's say this is the oral cavity, the alveolar sockets. So here you have is the upper teeth, and here you have is the lower teeth of the right side, and here you have is the tongue placed like this. Then here you have is the vestibule, and this vestibule is buccogingival vestibule between the cheeks and the teeth. In this vestibule surrounding here you find is the buccal mucosal glands. These are buccal mucosal glands secreting directly into the cavity, the buccogingival vestibule. The next thing here you find is this muscle, the buccinator muscle. This is a necessary muscle for chewing. This also helps in whistling, blowing air, and suckling. Remember the names I'm calling for the different colors because I'm not writing them. Then on to the outer surface of this muscle, buccinator, there is this fascia called buccopharyngeal fascia. Outside to that in the cheeks you have is the buccal pad of fat, the subcutaneous fat, enough of fat in the infants. This helps in suckling. Then, on outside, on the angle of the mandible, you find is a parotid salivary gland, which has long duct that is called Stenson's duct, which crosses the masseter muscle and then takes a medial twist. So this duct here, I am drawing here, is the parotid duct. This parotid duct pierces the buccal pad of fat, the buccopharyngeal fascia, and opens into the buccogingival vestibule opposite the upper second molar. Then in between here, between the buccal pad of fat and the buccopharyngeal fascia, you have these glands, the molar mucosal glands. These molar mucosal glands also perforate these two structures, the buccopharyngeal fascia and buccinator, to drain into the buccogingival vestibule. You also have some lymph nodes interpressed here in between, buccal lymph nodes. Then talking about the buccal branch of mandibular nerve, which is the only sensory division arising from the anterior division of mandibular nerve. Now this buccal branch, this descends down here, and it will supply the skin here on the cheeks. It will give cutaneous branches to supply the skin here on the cheeks. Then it perforates this buccal pad of fat, buccopharyngeal fascia, and the buccinator to supply the mucosa here, mucosa of the cheeks. And don't forget that it also innervates the mucosa here, the gingiva also, that is the outer surface of the gingiva facing the cheeks in this buccogingival vestibule. Opposite, you can remember the gums of the premolar and molar teeth on their outer surface towards the cheeks. They are also innervated by the same nerve, that is the buccal branch of mandibular nerve, V3 division of trigeminal nerve. Now talking about the buccal branch of facial nerve, remember that this buccal branch here in the upper diagram, I had shown you this one, the buccal branch. This is the buccal branch of facial nerve. So this buccal branch of facial nerve, of course, it supplies all the muscles of the facial expression except LPS, that is by oculomotor nerve. So this buccal branch of facial nerve, it will descend down here, it will perforate this buccal pad of fat and will supply this muscle buccinator. So remember the important point that buccal branch of facial nerve innervates buccinator, but it does not perforates buccinator because it has nothing to supply deeper down, right? So in this diagram, you can get this numbering here. Number 1 among the choices, this is A choice, the parotid duct. Buccal branch of mandibular nerve is this B choice. C choice, I have drawn it here, that is the buccal branch of facial nerve. And this one is the D choice, the molar mucosal gland. So you remember what are the structures piercing buccinator for your future exams? The structures piercing buccinator muscle are parotid duct, buccal branch of mandibular nerve, molar mucosal glands. But your answer here is innervates buccinator, but it does not pierces buccinator. Now let's presume in future sometime they might ask what are the structures pierced by parotid duct. So you can remember, firstly it will pierce buccal pad of fat, then the buccopharyngeal fascia, then buccinator muscle, and will drain into the vestibule. The question number 3 is lateral thyroid ligament of Bareilly is derived from buccopharyngeal fascia, pre-tracheal layer of deep cervical fascia, pre-vertebral layer of deep cervical fascia, investing layer of deep cervical fascia. Let's presume what I'm drawing here is the cricoid cartilage. So this is the cricoid cartilage, and you find is the thyroid gland overlying to this, embracing it like this. This is thyroid gland. Now this thyroid gland is of course lined by a true and a false capsule. True capsule is actually the thickening of the stroma of the thyroid gland itself, which is an inner layer. But the outer capsule of this thyroid gland is the false capsule, and this false capsule is a modification of pretracheal layer of deep cervical fascia. Now this same false capsule, it gets thickened here at two places, here and at here. The two thickenings at the posterior border of the thyroid gland, it becomes thickened, and along the inner margin, inner surface, which is resting over the cricoid cartilage. In the posterior border you will find is the vessels, and this is the ascending branch of the inferior thyroidal artery which runs along the posterior border of the thyroid. Then the same false capsule which thickens here, this is called ligament of Bareilly. So this ligament of Bareilly and the false capsule of the thyroid gland, both are modifications of the pretracheal layer of the deep cervical fascia. And this ligament of Bareilly helps this thyroid gland to bind it onto this cricoid cartilage line. Moving to next question. Question number 4. Base of occipital division of posterior triangle is formed by medial third of clavicle, intermediate third of clavicle, superior belly of omohyoid muscle, inferior belly of omohyoid muscle. Here it is this manubrium. This is the clavicle, and here from the mastoid it is sternocleidomastoid muscle with its two heads. Here it is trapezius, then it's the hyoid bone here, and from the suprascapular notch just medial to that there is this muscle called omohyoid. It has two bellies interconnected by a tendon in between. The tendon passes through a fascial tunnel here, and this one here you are seeing is triangle formed, that's called the posterior triangle. This posterior triangle is been divided into an upper portion called the occipital triangle. The lower one is called the suboccipital or the subclavian triangle. So here you are seeing that this muscle which divides this posterior triangle into two portions. The upper portion here it is called the occipital triangle, and this one is supraclavicular or subclavian triangle. So which muscle divides this, or you can say the base of occipital division of post triangle is formed by, you can see here it is this muscle. This is inferior belly of omohyoid. So the answer here it is inferior belly of omohyoid D. So that was question number 4. Next, let's move to question number 5. Question number 5 is, which of the following structures is not present in carotid triangle? Okay, now look here. Let's say this is the mandible, that's this external occipital meatus, mastoid process, and here it is the anterior margin of the neck, and posteriorly. And here you find is the hyoid bone. Here it is the manubrium, and here it is this clavicle. So you know that here there is this muscle. This muscle is sternocleidomastoid, and here it is this trapezius. Okay. Then here it is this superior belly of omohyoid, and here it is the inferior belly of omohyoid. Then here there's a pulley, and through this pulley there was this muscle digastric with its anterior belly and the posterior belly, and along with that there was another muscle in between here, and there was this muscle called stylohyoid also. There were two muscles here. Let's color it differently a little bit. I hope you can see that the two muscles there, one is stylohyoid and the posterior belly of digastric. Now what remains here, it is when you look it from the front, for your convenience I'm just making it like this so you can remember what is the anterior triangle actually made up of. So you're seeing here that this triangle here, posterior triangle, I've already discussed in the previous question. This is actually the anterior triangle of the neck, and this anterior triangle is divided into four triangles. One triangle you can clearly see here, it is this triangle here, and here another triangle, it's here, and another triangle is here, this one, and a triangle here like this. This triangle is carotid triangle. Right? So the carotid triangle, the boundaries you can see anterosuperiorly, it is by the posterior belly of the digastric as well as stylohyoid muscle. Antero-inferiorly, it is by this superior belly of omohyoid, and posteriorly it is by this upper portion of the anterior border of sternocleidomastoid. This triangle here is digastric triangle. So digastric triangle, the boundaries here, anterior-inferiorly, it is by the anterior belly of the digastric. Posterior-inferiorly, it is by the posterior belly of the digastric along with stylohyoid muscle. And superiorly, it is the base of the mandible and with the line that connects from the angle of mandible up to the mastoid. So that's digastric triangle. Here above to the hyoid and below to the chin, it is submental triangle. The submental triangle, the boundaries, the submental triangle is on either sides you find is the anterior belly of digastric, and the base will be formed by the body of hyoid. It's actually a triangle in the median plane, so it is bilaterally symmetrical with a line in between, that is the median plane. Similarly is the muscular triangle. Here you seeing this is the muscular triangle. Muscular triangle also lies in the median plane, so it's been divided by a line connecting from hyoid up to the suprasternal notch. So it's again, if you see the two triangles bilaterally joined together in the median plane. So the boundaries of this muscular triangle are posterior-superiorly, it is the superior belly of omohyoid, and inferiorly or infero-posteriorly, it is this the anterior border of the lower portion of sternocleidomastoid, and the base is formed by the median line connecting from hyoid to the suprasternal border or the jugular notch. Talking about the contents of this triangle, you can see only I'm drawing the required triangles here. One is this digastric triangle, and other one here it is the carotid triangle, right? So remember, all these nerves, 9th, 10th and 11th cranial nerve, they descend from this jugular foramen, and from the hypoglossal canal it is the hypoglossal nerve. So all these nerve, they're emerging just medial to the mastoid process from the base of the skull. So the last four cranial nerves, you'll find all of them coming down. So but only the glossopharyngeal nerve, that passes through the digastric triangle. Rest of the nerves, this is vagus. This one is the 9th cranial nerve. This is the 10th cranial nerve. Then you have is the 11th cranial nerve, which will move behind. This is the 11th cranial nerve. And of course, you will find is the 12th cranial nerve like this. So all these four cranial nerves you will find to be passing through the digastric triangle, But through the carotid triangle, ninth will not be passing because it does not descend down that much. And behind to the carotid sheath, you also find there's the sympathetic chain which descends down like this. So sympathetic chain, the beaded chain, will also be a content of this triangle. There's less of space here, so I'm not going to show you the further branches from these cranial nerves, although they might be asked sometime, but I'm going to explain it later on. Right now I just focus on the options given here. I've shown you all the options here. So hypoglossal nerve will be a content of this carotid triangle, vagus nerve will be a content, glossopharyngeal nerve, I have shown you that it is a content of digastric triangle, but it's not a content of carotid triangle. Sympathetic chain will be there in the carotid triangle. Now talking about the sixth question, which of the following structure lies in the lateral wall of cavernous sinus? Abducent nerve, mandibular nerve, facial nerve, trochlear nerve. So such questions are repeatedly being asked, so you should have this idea about the cranial cavity. So there you seeing this portion here, this is the body of sphenoid, and this body of sphenoid, it's a pneumatic bone. It has these sphenoidal air sinuses which may not be symmetrical, and then you have the meninges lining. This will be the endosteal layer of the dura mater covering it like this, and another, you can presume that from here this is the meningeal layer of dura mater. This meningeal layer of dura mater, it reaches above like this, and then it provides space. It forms actually the diaphragma sellae, from which this stalk of pituitary suspends down into the sella turcica like this. So this portion here, it is the sella turcica, which lodges this pituitary. It is this pituitary gland suspended here like this, and this portion here, it is the diaphragma sellae. This forms the diaphragma sellae. Then talking about the nerves, so remember that in this cavernous sinus, there is this internal carotid artery which has a sigmoid course within this, that's called carotid siphon. Just infralateral to this artery in the medial wall of the cavernous sinus, you find this nerve, that is abducent nerve. And in the lateral wall of the cavernous sinus, you find is oculomotor nerve, which although in the anterior portion, which splits into superior and inferior division of oculomotor nerve, then you have is this trochlear nerve, the fourth cranial nerve, and sixth you have already seen here. And trigeminal nerve, that's a Gasserian ganglion, which lies at the apex of this petrous temporal bone. It's a bean-shaped ganglion, and from there are three branches, V1, V2. So V1 will pass through here, and V2 will also pass through here to the cavernous sinus. However, V3 division, that's the mandibular division, that immediately sinks down and emerges out through the foramen of ovale. Let's name these. This is third cranial nerve. It divides into upper and lower divisions of oculomotor nerve and will reach into the orbit through the superorbital fissure. Fourth cranial nerve, which also reaches into the orbit through the superorbital fissure. This is V1 division of trigeminal nerve, also called ophthalmic division of trigeminal nerve. It splits into frontal, lacrimal and nasociliary divisions and enters into the orbit through the superorbital fissure. This one is V2, which is maxillary division. It continues here on the lateral wall, the lowest nerve in the lateral wall, and then emerges out through foramen of rotundum into the pterygopalatine fossa, where it suspends the pterygopalatine ganglion. So remember that this sinus, rather all the intracranial dural venous sinuses, they are lined by this endothelium, and here it is this venous blood collected here. So this is how you find is cavernous sinus. For your convenience, I'm drawing so that you remember that V3 division lies outside to this cavernous sinus. So the answer here, which of the following structures lie in the lateral wall of the cavernous sinus? Abducent nerve is in medial relation. Mandibular nerve is outside the cavernous sinus. Facial nerve has no relation with this. Facial nerve passes through the internal acoustic meatus and emerges to the stylomastoid foramen. Trochlear nerve, of course, is the answer here. I have just now shown you. Question number 7. Middle constrictor muscle of pharynx arises from. It should actually be written as or takes origin from, which would have been a better statement. Arises, actually it comes in mind there's for the brachial apparatus. It arises from the fourth laryngeal arch. Anyway, so middle constrictor muscle of pharynx arises means takes origin from. Mandible, greater cornu of hyoid bone, thyroid cartilage, cricoid cartilage. So for your revision, just have a look here. Just remember the three main thing you have is the mandible, one thing. Then you have, just remember it's like this, the mandible, the angle of mandible. Then you have is the hyoid like this, right? This is the hyoid. And then you have is the thyroid cartilage like this. And below to that, of course, is the cricoid cartilage. If you remember these three structures in the neck, above mandible, then hyoid, then the larynx. So you can easily learn the three constrictors because the three constrictors are related to these structures. But if you see further details, if I want to show you, behind there was this pterygoid. From the medial pterygoid plate, there was this pointed projection called pterygoid humulus. From pterygoid humulus to the inner surface of the angle of mandible, there is this raphe attached called pterygomandibular raphe, and here you'll find is the styloid process. From styloid process up till this greater cornu of the hyoid, there is this ligament, stylohyoid ligament. And from this pterygoid plate, the medial pterygoid plate, reaching up to this base of the skull, that is the body of sphenoid undersurface, as well as the occipit, primary cartilaginous joint, that is spheno-occipital joint. After fusion, it forms the basi-occiput, and onto the undersurface there is a tubercle called pharyngeal tubercle. So this is one of the modifications of the deep fascia, and this is called pharyngobasilar fascia. And all these constrictors, they are like a glass kept over to another glass like this. Means what? The superior will be invested on its lower surface on outside by the middle constrictor. Middle constrictor on outside will be covered by the inferior constrictor. And posteriorly, all of the three constrictors, they join to form a median raphe in the midline, and that median raphe reaches up to join on this pharyngeal tubercle. So here, I'm telling is about the superior constrictor. You can imagine what I'm drawing here. It is like this, something like this. This is the posterior border, the posterior raphe formed by the insertion of these three muscles. So this is like the superior constrictor taking origin from the pharyngobasilar membrane, lower border, pterygoid humulus, pterygomandibular raphe, as well as the inner surface of the angle of the mandible, the posterior end of the mylohyoid line, which you call that, and also from the upper portion of the stylohyoid ligament. That was superior constrictor. Then talking about the middle constrictor. Middle constrictor, you can see it takes origin from this stylohyoid ligament, lower portion, posterior border. Then from this greater cornu of the hyoid bone, the upper border of the greater cornu of the hyoid bone, as well as from the inferior cornu of the hyoid bone. Then remember that on the larynx, on the thyroid cartilage, there is an oblique line. And from that oblique line of the thyroid cartilage, there is this fibers of the inferior constrictor. These fibers of the inferior constrictors, they take origin from this thyroid cartilage and wind behind like this. And it also takes from the cornu of this thyroid cartilage, and there's an inferior cornu, superior inferior cornu of the thyroid, oblique line of the thyroid. And all these fibers, they circumferentially wind and posteriorly merge in the median plane posteriorly to form a raphe. And this inferior constrictor actually is divided into two parts. You have this portion called thyropharyngeus. There's a ligament tendinous band connecting from the lateral portion of this thyrohyoid muscle and reaches to this thyroid cartilage. right? So from this tendinous band as well, the fibers of this thyropharyngeus muscle take origin, and then lastly the lower portion of the inferior constrictor, which we call as the cricopharyngeus muscle, that takes origin from this tendinous band as well as from the cricoid cartilage lateral to the attachment of cricothyroid muscle. So in short, you have, like, let me number them all. This one is superior constrictor, although there are further subparts named according to the origin from different structures, which I'll tell you sometime later. And this one was middle constrictor, and this was thyropharyngeus muscle, and this was cricopharyngeus muscle. Together they're called as inferior constrictors. Although remember, these are the three constrictors and there are three longitudinal muscles also running in this pharynx. The three longitudinal muscles are stylopharyngeus, then salpingopharyngeus, and palatopharyngeus. One more important thing to remember, just because I'm discussing upon the constrictors of the pharynx and the muscles of the pharynx. So remember, I just told you they are taking origin from the fourth pharyngeal arch. So all these muscles of the pharynx, they innervated by pharyngeal plexus, which also is called vago-accessory complex, which is actually formed by vagus as well as the cranial portion of accessory nerve, and those are actually motor in supply, but sensory innervation is by glossopharyngeal nerve, and the sympathetic fibers also mingle with that to form the pharyngeal plexus. But one more thing, the important portion about it is that all these muscles, they will be supplied by vago-accessory complex of the pharyngeal plexus, except this one, remember, the cricopharyngeus, which actually is innervated by the nerve of the sixth arch, and that is recurrent laryngeal nerve. This one, the last one. So here what they have asked is about the middle constrictor muscle of pharynx arises from mandible nerve, greater cornu of hyoid bone, thyroid cartilage, cricoid cartilage. So you've seen that this middle constrictor actually is taking origin from the stylohyoid ligament, greater cornu, upper border, and the lesser cornu. So among the given options, you will find that this one is the correct choice, B. Next question is question number 8. Which of the following is not a feature of Horner's syndrome? Ptosis, anhidrosis, dilated pupil, and ophthalmos. So remember that Horner's syndrome is actually loss of sympathetic innervation to the orbits, and that is associated with the low injury to the lower trunk of brachial plexus as well. That's called clump case paralysis. So Horner syndrome, all the sympathetic innervation to the structures in the orbit is lost. So what will be the symptoms of Horner syndrome? Remember the symptoms. One is meiosis, anhidrosis, ophthalmos, partial ptosis, loss of cerebrospinal reflex. Okay, so meiosis is, why is this meiosis? Because remember that dilatation of the pupil is by dilator pupillae muscle, and which is innervated by sympathetic. So when sympathetic supply is lost, obviously the constrictors of the pupil will dominate, and that will lead to meiosis, constriction of pupil. Anhidrosis is because of loss of secretions from this glands within the orbits, and ophthalmos is because there's this muscle in the floor of the orbit, the orbitalis, which is a smooth muscle which bridges the inferior orbital fissure. So if that gets paralyzed, the eyeball actually sinks a little posteriorly, and that results in an ophthalmos. Partial ptosis because this muscle LPS, levator palpebrae superioris, which is innervated by oculomotor nerve, the portion of the skeletal muscle, but it also has a smooth muscle component which is innervated by the sympathetic fibers, that's called Muller's muscle. So paralysis of those Muller's muscle will lead to partial ptosis. And of course there will be loss of cerebrospinal reflex, which is like when you clench the back of the neck, there is like tight closure of the eyelids, and that is mostly seen in the animals, the lower animals. So answer here will be, which is the following not a feature, right? Ptosis is a feature, which actually is a partial ptosis. Anhidrosis, dilated pupil, no, you will find it's constricted pupil, that is meiosis, and ophthalmos will be there. Question number 9. Cerebral aqueduct connects lateral ventricle with the third ventricle with the fourth ventricle, right and left ventricles, fourth ventricle with the central canal. Just fast revision. Hope you remember about the circulation of CSF. This, I hope you've understood what I have drawn here. This is cerebral hemispheres, and this is the diencephalon, and this is the midbrain. This is the pons, this is medulla, and this is spinal cord, and these are cerebellum. And remember that cerebral hemispheres are also referred to as telencephalon. So the cavity of the telencephalon is called the ventricular cavity. These are the lateral ventricles, the two lateral ventricles, and they get connected in between here at this point by interventricular foramen of Monro. Then that communicates it to the cavity of the diencephalon, and this cavity of the diencephalon is called the third ventricle. This cavity of third ventricle continues like a duct passing through the midbrain, and then again it becomes rhomboid shaped on the dorsal aspect of the pons, and that's called the fourth ventricle, which continues down as the central canal in the spinal cord like this, reaching up to the medulla. This cavity of the fourth ventricle is actually resting over the dorsal surface of pons as well as upper portion of medulla, and down below at the point called obex it continues down as the central canal of the spinal cord. In the question they have asked, the cerebral aqueduct connects. Let me once again name them. This point, remember, is foramen of Monro, cerebral aqueduct, which connects the third ventricle to the fourth ventricle, and itself it's the central cavity of the midbrain, and this point here is called obex. And remember, this central ventricular system gets connected to the subarachnoid space filled with CSF. So the communication is through the fourth ventricle. So in the roof of the fourth ventricle, there's a median aperture that's called foramen of Magendie, and the two lateral apertures called the foramen of Liska, through which the CSF gets communicated to the subarachnoid space. Just to add up in this question, here you have is in the roof of the fourth ventricle is foramen of Magendie, and on the two sides lateral in the lateral recess of the fourth ventricle you find is foramen of Luschka. So M for median, M for Magendie, L for lateral, L for Luschka. So I hope you've got the answer now, that the cerebral aqueduct connects third ventricle to the fourth ventricle. Fibers of optic radiation. Now question number 10. Fibers of optic radiation pass through which of the following parts of internal capsule? Anterior limb, posterior limb, sublentiform part, retrolentiform part. So let's do a fast revision about this internal capsule. It's really very important. So here you find, this is what I'm drawing is the superior view of the right cerebral hemisphere. So this will be the head of the caudate nucleus, and here you finding is the thalamus, and here you find is the lentiform nucleus, which has the two portions. The outer portion is the putamen and the inner portion is the globus pallidus. In between, what you're finding here, this thing is the space for the passage of the fibers ascending and descending down, a big highway for the pyramidal tract or the corticospinal and the corticonuclear fibers, and of course the ascending fibers as well. So this portion here is a V-shaped thing. This is internal capsule. This portion here, the anterior limb of the internal capsule. This is the genu of the internal capsule. This is the posterior limb of the internal capsule. This is the anterior limb of the internal capsule. This is the genu of internal capsule. This is the posterior limb of the internal capsule, and this is sublentiform portion, and this one is retrolentiform portion of internal capsule. So now remember about what they have asked. The question is about the optic radiation. Remember, in the upper portion of the dorsal aspect of the midbrain there was the corpora quadrigemina made up of two pair of colliculus, superior and inferior colliculus. From the superior colliculus, the fibers pass out and pass through the retrolentiform portion of the internal capsule and then reach out to the occipital lobes of the cerebral hemisphere in the form of optic radiation. So this is optic radiation. Now this is inferior colliculus. This was superior colliculus. So from inferior colliculus, the fibers will pass out like this through the sublentiform portion of the internal capsule and will reach out to the temporal cortex, to the auditory areas. This is the auditory radiation. Auditory radiation. But in the question what they've asked is about the optic radiation. So optic radiation, fibers pass through which parts of the internal capsule? The answer is easy. It is the retrolentiform portion of the internal capsule. Question number 11 is about which of the following is an example of pneumatic bone? Maxilla, patella, pisiform, coracoid process of the scapula. You know, the skull is made lighter because of those pneumatic bones surrounding the nasal chamber, the nasal cavity, and which also provides additional advantages like resonance of voice, air conditioning to the airway inspire. So among the given options, maxilla is a pneumatic bone because there is a sinus inside, the maxillary sinus. Other pneumatic bones you can include is ethmoid, sphenoid, frontal. The anterior portion of the frontal bone which lodges the superciliary arches above the supraorbital margins. So there you find is the frontal sinuses. So these are the few of the pneumatic bones of the skull. Answer is maxilla. Question number 12. The characteristic feature of skeletal muscle is peripherally placed nucleus, intercalated discs, spindle-shaped muscle fibers, branching muscle fibers. I'm not going to spend enough time on this. It's an easy question. So remember, peripherally placed nucleus is a feature of skeletal muscle fibers. Of course, striated fibers. You will find light and dark bandings here, but of course this also will be seen in cardiac muscle as well. So peripherally placed nucleus is a more important feature. Then intercalated disc is a feature of cardiac muscle. Spindle shaped muscle fiber is a feature of smooth muscle. Branching muscle fiber is also a feature of cardiac muscle. Cardiac muscles are also striated fibers. So the answer is peripherally placed nucleus is a characteristic feature of skeletal muscles. Question number 13. Which of the following type of epithelium is present in trachea? Simple squamous, simple cuboidal, pseudostratified, simple columnar, simple columnar. It's an easy thing. Remember, the hallmark feature for identifying trachea is two features. One is pseudostratified ciliated columnar epithelium plus hyaline cartilage. That's this horseshoe-shaped or semicircular cartilaginous ring of this trachea. Question number 14. Which of the following is a derivative of ectoderm? It's so easy thing because they have asked is about intestines, kidney, ovary, neural tube. No doubt neural tube is the answer, which is derived from ectoderm, which develops into the central nervous system, the brain and the spinal cord. Question number 15. Which of the following is X-linked recessive disorder? So X-linked recessive disorder is hemophilia, Turner syndrome, sickle cell anemia, hypertrichosis. So remember that hemophilia is the answer here and it is X-linked recessive disorder. Other X-linked recessive disorder you can just remember there are few. One is red green color blindness, diabetes mellitus also comes in this categories. Duchenne, remember Duchenne muscular dystrophy, Becker's muscular dystrophy, and G6PD deficiency, that is glucose 6-phosphate dehydrogenase deficiency. There are many in the list. I'm just giving you the important ones. In case they asked sometime about X-linked dominant disorders. So X-linked dominant, at least few you should remember the important ones. One is hyperphosphatemia. Remember this, hyperphosphatemia. Vitamin D resistant rickets. And there's another problem, that is XG blood groups. Now, Turner syndrome is an example of aneuploidy. Aneuploidy is when the normal chromosomal pattern, that is 46 chromosome, is disrupted. Here it is monosomy of X chromosome. You find only one X chromosome. So this one is XO type of monosomy. Sickle cell anemia is autosomal recessive disorder, and in this category you can remember one with the sickle cell anemia, there is Tay-Sachs disease as well as cystic fibrosis. This might be options sometime in future, so just the few important ones I'm mentioning here. Then hypertrichosis pinna, it actually is called. Hypertrichosis pinna is when you have enough amount of hairs on the pinna, and this actually is a feature of only found in males. This is actually a Y-linked disorder. I hope you got the answer now. So hemophilia is X-linked recessive disorder. Question number 16. This is about the vertebral level of inferior angle of the scapula. So on the dorsum, when you see there's the spine here, and you find is the scapula placed here, like this. I have already uploaded few of my lectures on the dissection of trapezius and the surface anatomy of the back, the bony prominences of the back. There are many videos uploaded on this. Inferior angle of the scapula rests or that touches this 8th or sometimes the 9th rib. If you consider this 8th rib, which is most oftenly found, this question is not actually a very genuine type of question, because the angle of this positioning of the angle of the scapula, all this matters on different factors. One is the position of the body, which actually should be an anatomic position in an erect posture, but inferior angle, the position keeps moving while lying down supine. And while lying down prone, actually in lying down prone, the scapula slips a little half centimeter above superiorly, or half inch sometimes, and then adducting the shoulders. Then age variations, sexual variations, all, and racial differences also are there. So this angle of scapula, actually, if you follow the Gray's anatomy, they have written it as the 9th rib. This inferior angle touches the 9th rib, and you know that the 9th rib takes origin from in between the 8th and 9th thoracic vertebrae. So actually there's a lot of variations. If you find the books, the scholarly articles, the inferior angle of the scapula, the exact measurement is still not confirmatory, because there's a lot of variations available. So just remember it this way, that there can be T7, T8 or T9. All of them will be marked correct. And if they talk about the ribs, same pattern will be asked in ribs also. So all of them, remember that 7th, 8th and 9th rib, all of them be correct. Such questions, you should not get all these options 7, 8, 9 in an MCQ. Only one of these will be there in your MCQ. Like here in the question, they have asked about the inferior angle of the scapula, and out of these 7, 8 and 9, they've only given T7. So this question remains undisputable. So the answer is D, T7. Next question is about the variety of superior radial joint is pivotal variety, ball and socket variety, saddle variety, ellipsoid variety. Remember, all these are varieties of synovial joint. Look, what I'm drawing here is the lower portion of the anterior surface of right humerus. It's like this. So this is the upper end of a radius, which is discoid, disc shaped, and it's like this. It has a radial tuberosity here. And here you have is the coronoid process of the ulna. It's this, the ulna with the coronoid process. Your purpose here to look on this diagram which we are talking is about this joint. This is a spherical thing, a hemispherical thing. This is called the capitulum. And here inferiorly it is a disc shaped thing, head of radius, which is concave above in reciprocation to this to the convexity of the capitulum. So when this joint is formed is a ball and socket variety of joint, which actually provides the rotatory movements of the radius. So this joint you are seeing is radio-humeral joint. One more thing here, you see that onto this surface of the ulna there is a radial notch. This radial notch actually provides space for the head of the radius to fit in and to provide the rotatory movements along to this. What has been asked in question is about the superior radio-ulnar joint. The superior radio-ulnar joint is this joint we are talking about. This joint is superior radio-ulnar joint, and this joint is radio-humeral joint, and there will be a inferior radio-ulnar joint as well. Both superior and inferior radio-ulnar joint, both of them are examples of pivotal joint because they provide this rotatory movements for supination and pronation. But if they ask about the radio-humeral joint, which is a part of elbow joint, this radio-humeral joint is a variety of ball and socket joint. And in case if they ask about this joint, Humero-ulnar joint, this is hinge joint. Question number 18 is about nerve damage in inferior dislocation of humerus. Look here, this is the scapula with the glenoid facet, and here it is this humerus, greater tubercle, lateral epicondyle, capitulum, trochlea, medial epicondyle. So this is the anatomical neck. Here it is the surgical neck of humerus. And talking about the nerves in intimate relations, remember this nerve is axillary nerve, which winds behind to this posterior surface of the surgical neck of the humerus, and that is axillary nerve. Another nerve is radial nerve, which passes behind the shaft of the humerus in the radial groove, that is radial nerve. And one more nerve, it passes behind the medial epicondyle of the humerus, and that is ulnar nerve. So you have three nerves that you need to remember. One is axillary nerve, and this is radial nerve, and this is ulnar nerve. So these three nerves are in intimate contact with humerus, so there are very much chances of injury of these three nerves. However, in the arm there are two nerves which do not touch the humerus. One is median nerve and the other is musculocutaneous nerve. So the question is about the nerve damage in inferior dislocation of the humerus. Of course, if the humerus dislocates inferiorly, so remember that this nerve, the axillary nerve, is going to be damaged. So the answer will be axillary nerve. Question number 19 is clavipectoral fascia is not pierced by thoracoacromial artery, lateral pectoral nerve, medial pectoral nerve, cephalic vein. So fast revision about this also. Let's see that this is the cut section of clavicle, and here you are drawing is the breast, and of course here will be the axilla. So remember about the structures which I am drawing here. This will be pectoralis major. This is pectoralis major, that is forming the bed of the breast, and here below to that will be pectoralis minor, and onto the under surface of the middle 1/3 of the clavicle there is insertion of this muscle subclavius, and behind posteriorly it's this muscle subscapularis, teres major, and the twisted tendon of latissimus dorsi. So in case now at this point you got to know about the muscles forming the anterior wall of the axilla. One is pectoralis major and pectoralis minor, the two muscles, and subscapularis, teres major, and latissimus dorsi. These three muscles, they form the posterior wall of the axilla. There is this clavipectoral fascia which actually invests this muscle subclavius and descends down like this, and then invests this muscle pectoralis minor, further descends down to get inserted into the deep fascia of the floor of the axilla that forms the suspensory ligament of the clavipectoral fascia. In some time it was asked as the tendon of clavipectoral fascia. So remember, the tendon of clavipectoral fascia is the continuation of this clavipectoral fascia to the floor of the axilla. So this is the suspensory ligament. Clavipectoral fascia is actually this portion. This is clavipectoral fascia. So what are the structures piercing, from the front? Actually, it is reaching behind is cephalic vein. This is cephalic vein. Then you have the lymphatics. The lymphatics from the deeper surface of the breast, they also perforate the clavipectoral fascia and drain into the apical group of axillary lymph nodes. And from inside the cavity, there is this branch from the second part of the axillary artery, that is thoracoacromial artery, which perforates this clavipectoral fascia. Sometimes even it has been found that the thoracoacromial artery does not pierces, rather its branches pierce the pectoral branch of the thoracoacromial artery. And this nerve here, the lateral pectoral nerve, also pierces this clavipectoral fascia. So I hope you understood now. This is lateral pectoral nerve and this is thoracoacromial artery, and this is lymphatics, deep lymphatics from breast. So in the question what they have asked is clavipectoral fascia is not pierced by thoracoacromial artery, lateral pectoral nerve, cephalic vein. Of course the answer will be medial pectoral nerve. So medial pectoral nerve, remember, it pierces. This will be the course. In the same diagram, let me draw here it for you, that it is the course of medial pectoral nerve. So remember, this medial pectoral nerve pierces directly. It pierces and supplies pectoralis minor and then reaches down on the undersurface of pectoralis major to supply it. Medial pectoral nerve, instead of piercing clavipectoral fascia, it pierces pectoralis minor and supplies both the pectoralis major and minor. In fact, the nerve supply of both pectoralis major and minor is by both the pectoral nerves, medial and lateral pectoral nerves. The last question is about bone involved in Colles fracture is scaphoid first metacarpal lunate radius. This is the right radius medial view. In a pronated wrist, it articulates with the two carpal bones at its lower end. One is scaphoid and the other one is lunate. Triquetral is there. It participates in formation of the wrist joint, but it does not articulates with the radius directly, and you form is the pisiform above. You have this ulna also at the lower end, but ulna, it does not participates in the wrist joint because of this intra-articular disc. The disc here is this thing. Because of this disc, ulna does not participates in formation of the wrist joint. So the bones here are scaphoid, lunate, triquetral and pisiform. Ulnar radius. Now what happens is at the corticocancellous junction. So what happens in Colles fracture is at the corticocancellous junction, there is a fracture on when fall on an outstretched hand. What happens is this distal portion of the radius gets fractured and gets dislocated. Now what happens after fracture is that this distal portion, the distal segment, the fractured portion gets displaced dorsally and proximally. And along with that will be scaphoid and lunate, and of course the entire hand will get dislocated like this. That becomes a deformity. Now this deformity is because of the dorsal and proximal subluxation of the distal fragment of radius. So this is called Colles fracture. This deformity you can see is like this, like a dinner fork. So this is also called dinner fork deformity. In case, remember, if the reverse happens, that this distal fragment, the distal broken fragment gets dislocated on the palmar side, ventrally and proximally, then it will be called Smith's fracture and dislocation. So the answer here is bone involved in Colles fracture is of course the radius. So that was all about the MCQs. For those who want to see the question paper, just can have a look fast. So part B was of 40 marks, that the long question of 15 marks was on describe brachial plexus in the following headings: formation, branches from different parts, applied anatomy. Then 5 marks question was on lacrimal apparatus, corpus callosum. 5 marks applied question was on Bell's palsy. Then there was a question on histology of lymph node of 5 marks. Then there was 2.5 marks, 2 question, formation of trilaminar embryonic disc and on tympanic membrane. Part C was of 40 marks. So the question was describe thyroid gland under following headings. This was a long question of 15 marks, including gross anatomy, blood supply, and applied anatomy of the thyroid gland. Then short notes, 5 marks each. One was this question on ATCOM about proper handling of cadaver in dissection hall and pyramidal tracts. Question number 3 was on write short notes on carpal tunnel syndrome. This was also 5 marks. There was a clinical question here. A 6-year-old boy came to ENT OPD with complaint of painful deglutition. On examination, bilateral swelling of lymphoid tissue is seen in oropharynx. Write briefly the anatomy of the structures involved. So this is a case of tonsillitis, and because of that there is dysphagia. So here you have to write about the anatomy of tonsils. Write short notes again, 2.5 marks, fibrous joint and Down syndrome. So that was all about this question paper.